Now we are going to discuss bile duct. So first we are going to discuss the anatomy of bile duct. So see, this is liver, this is gallbladder, this is bile duct. Okay. Now see, in the bile duct, this is common hepatic duct, right? So what is the length of common hepatic duct? The length of common hepatic duct is 1 to 4 centimeter. How much is the length? Length is 1 to 4 centimeter. And what is the diameter of common hepatic duct? It is 4 millimeter. So the diameter is 4 millimeter. Now see, this is the common bile duct. Okay, what is the length of common bile duct? It is 7 to 11 centimeter. So the length that is 7 to 11 centimeter, and the diameter is 5 to 10 millimeter. So diameter, it is 5 to 10 millimeter, right? So this is the basic anatomy. After that, important point is, now we are going to discuss the blood supply of bile duct, which is very important and frequently asked in exams. So see the blood supply. Bile duct is having coaxial blood supply. Okay, so bile duct is having coaxial blood supply at 3 o'clock and 9 o'clock position. So see the blood supply. You can see it is coaxial at 3 o'clock and 9 o'clock position. Now in the diagram you can see that 60% blood supply is going from below and 38% from above, right? So 60% from below and 38% from above. That's why we are not going to put, or we are not going to make transverse incision in the bile duct, because if you are going to put or make transverse incision in the bile duct, then what is the problem? After making transverse incision, what is the problem? The blood supply from below is hampered and it leads to stricture formation. That's why in bile duct injury, what kind of incision should be given? It should be longitudinal, so that we are not going to injure the blood flow from below or blood supply from below. Now see, what are the vessels which contribute to the blood supply of bile duct? Now from below, here you can see this is the pancreaticoduodenal artery and this is the retroduodenal artery. So from below, 60% blood supply from below by pancreaticoduodenal artery and by retroduodenal artery, right? And from above, how much blood supply? 38% blood supply from above by, here you can see this is cystic artery, and this one is right hepatic artery, right? So this is cystic artery and right hepatic artery. Clear? So how to remember? Yes, remember how to remember. There is a mnemonic: 60% from below, so नीचे से PR, and 38% from above, so ऊपर से CR. So how to remember? नीचे से PR means pancreaticoduodenal artery, retroduodenal artery, ऊपर से CR means cystic artery and right hepatic artery. So this is the blood supply. In AIIMS, there was one question that how many sphincters are there in sphincter of Oddi complex? Okay, and it's a controversial question. If you open belly, similar diagram is given in the belly and 4 sphincters are depicted in the diagram. And if you see the Shackelford, which is the Bible of GI surgery, in that it is typically written that there are 4 sphincters in the sphincter of Oddi complex. So what are the 4 sphincters? Sphincter of Oddi complex. So this is sphincter of Oddi complex. What are the 4 sphincter? You can see here, first one. So first is superior choledochal sphincter. It is superior choledochal sphincter, right? And what is the second one? This is inferior choledochal sphincter. What is this third one? Third is around ampulla. So this is sphincter ampullae. And the fourth is around pancreatic duct. So this is sphincter pancreaticus, right? So third is sphincter ampullae. Clear? And the fourth is sphincter pancreaticus. It's sphincter pancreaticus. right? So how many sphincters? There are 4 sphincters in relation to sphincter of Oddi complex. Now we are going to discuss very important topic, that's choledochal cyst. So what is choledochal cyst? Choledochal cyst is dilatation of bile duct and it is congenital. Since it is congenital, it is more common in children and it is more common in females. So choledochal cyst. This is dilatation of bile duct. We discussed this is congenital, and since it's congenital, it is more common in children and it's more common in females. Okay, now see what is the pathophysiology. There is most accepted hypothesis, one most accepted hypothesis, and what is that most accepted hypothesis in choledochal cyst? That is APBDJ. So what is the most accepted hypothesis? It is APBDJ. Okay, what is the full form of APBDJ? Abnormal pancreatico-biliary duct junction, right? What is the simple concept behind this? See this diagram. If you see, this is the liver, this is the gallbladder, this is the bile duct, and this is the pancreatic duct. Okay, now here you can see this is the common channel. The common channel means where bile and pancreatic juice is having a common channel, so that it is going to pass through that common channel and finally going to enter into duodenum, right? This is normal. Now see the second diagram. If you see this second diagram, what you can make out here, see. So if you see the length of common channel, here it's very long. So here it's a long common channel. Now the problem which will occur in this case, because of this abnormal pancreatico-biliary duct junction, see, there is reflux of pancreatic juice into the bile duct. Because of this abnormal pancreatico-biliary duct junction, all of you must be knowing that what is the composition of pancreatic juice. Pancreatic juice contains digestive enzymes like amylase, lipase, RNase, DNase, proteinase, elastase. So most of the digestive enzymes are there in the pancreatic juice. What is the problem with bile duct? That in the muscle layer of bile duct there are scanty muscle fibers. So the muscle layer is having scanty muscle fibers, but there is presence of elastin. So in the muscle layer there is presence of elastin, and the pancreatic juice is having elastase, which is going to digest elastin. And if it is going to digest elastin, what will happen? There is weakness of the wall, and because of this weakness, what's the problem? There is dilatation, and this dilatation is known as what? Choledochal cyst, right? So be careful. This is what? Abnormal pancreatico-biliary duct junction, which is the most accepted hypothesis. Now see the classification system for choledochal cyst. What is the name of classification system? It is known as Todani modification of Alonso-Ledge classification. So the name of classification system, it's very important. It's Todani modification of Alonso-Ledge classification. Okay. Now what is the most common type? It's type 1. And what is type 1? It's the dilatation of extrahepatic bile duct. Type 1 is further divided into type 1A, 1B, 1C. So see, this is liver. What is type 1? Type 1 is dilatation of extrahepatic bile duct. Clear? And it is further divided into 1A, 1B and 1C. So what is 1A? 1A is cystic dilatation. 1B is focal segmental dilatation and 1C is fusiform dilatation, right? So 1A is cystic dilatation. 1B is focal segmental dilatation, and 1C is fusiform dilatation. Clear? Now what is type 2? In type 2 there is diverticular formation. So there is diverticular dilatation. So see the diagram. This is type 2. In the type 2 you can see here there is diverticular formation. So this is diverticular dilatation, right? So type 2, this is diverticular dilatation. What is type 3? Type 3 is a bit different. In type 3, the intraduodenal part of bile duct is dilated, and means the terminal part. So intraduodenal part of bile duct is dilated, and that is known as choledococele. You must be knowing that if the terminal part of ureter is dilated, that is known as ureterocele. So if bile duct terminal part is dilated, which is in the duodenum, that's known as choledococele. So what's type 3? This is type 3. So in this type 3, this terminal part means the intraduodenal part is dilated, and the other name for type 3, it's choledococele. Right? Now type 4 is further divided into 4A and 4B. In 4A, there are multiple cysts involving both intrahepatic as well as extrahepatic bile duct, whereas in 4B there are multiple cysts involving only extrahepatic bile duct. So you can see here that this is type 4A, and in type 4A there are multiple cysts involving both intrahepatic as well as extrahepatic bile duct. Clear? So multiple cysts involving both intrahepatic bile duct plus extrahepatic bile duct. Right? Now see, what is type 4B? So if you see this diagram, this is type 4B. In type 4B there are multiple cysts involving extrahepatic bile duct only. Right? So this is type 4B, in which there are multiple cysts involving extrahepatic bile duct only. And type 5 is known as Caroli's disease, in which there is involvement of intrahepatic bile duct only, and there are presence of multiple cysts. Right? So see, this is the diagram, and in type 5 there are multiple cysts involving only intrahepatic bile duct. Clear? And this is also known as Caroli's disease. Simple. So these are the 5 types. Now question is asked that what is the most common type of choledochal cyst, and the most common type is type 1. Let me tell you one simple logic. If you see the most of classifications systems in the surgery, you will notice that in majority of classification system, if classification system starts from 1, 2, 3, 4, 5, then the most common type is type 1. And if classification starts from A, B, C, D, E, then the most common type is type A. See, this is correct only in 80% cases, and not in all cases. So if in exam you don't know the answer, you can either mark type 1 or type A, and you will be correct 80% of times. So see, what are those classification systems where type 1 is most common? So first, choledochal cyst. Second, hiatus hernia. Third, gastric ulcer. Fourth, fistula in ano. Fifth, posterior urethral valve. So in all these cases, type 1 is most common. And if we are talking about type A, B, C, D, E, so type A is Strasbourg classification, which is most common. And if you see the luminal criteria for breast cancer, in that case also type A is most common. Okay, so see the classification systems. Type 1, it's most common in, what are the examples? First is choledochal cyst, right? Second is hiatus hernia. Third is gastric ulcer. Fourth is fistula in ano. And fifth is posterior urethral valve. It's the posterior urethral valve. Now see type A. See type A. Type A is most common in first Strasbourg classification of laparoscopic bile duct injuries and luminal criteria for breast cancer. Luminal criteria for breast cancer. Simple. So if we apply the same logic, what is the most common type of choledochal cyst? The most common type of choledochal cyst is type 1, followed by type 4, followed by type 3. So in choledochal cyst, the most common type is type 1, followed by type 4, followed by type 3. So how to remember? This is 143. So what is the meaning of 143? You must be knowing. We have to send this message just before midnight to one person only. 143 means I love you, right? If you apply the same logic in choledochal cyst, in type 1 it is further divided into type 1A, type 1B, type 1C. So in type 1, most common overall, obviously it's type 1A. So here overall most common is type 1A. Now see, we discuss this. Before discussing anything, we can discuss directly the management, which is very easy. See, there is a simple concept. We cannot repair intrahepatic bile duct. So if you cannot repair intrahepatic bile duct, any condition in which intrahepatic bile duct is diseased, in all those conditions, what is the treatment of choice? Is the liver transplantation. That's why primary biliary cirrhosis, where there is involvement of intrahepatic bile duct only, treatment of choice is liver transplantation. Primary sclerosing cholangitis, there is involvement of intrahepatic bile duct as well as extrahepatic bile duct. And since there is involvement of intrahepatic bile duct, what is the treatment of choice? It's liver transplantation. If you see the 5 types, in this you can see that in type 4A, there is involvement of intrahepatic bile duct, and in type 5, there is involvement of intrahepatic bile duct. So in type 4A and 5, what is the treatment of choice? It's the liver transplantation. Simple. Second principle, when only extrahepatic bile duct is diseased, you have to excise the extrahepatic bile duct and you have to restore the continuity. So see, if you see this diagram, this is the part of extrahepatic bile duct, and since this is the part of extrahepatic bile duct, what I will do, I will excise this extrahepatic bile duct. Now if you see this type 2, in type 2, this extrahepatic bile duct is diseased. What you do, you excise this extrahepatic bile duct. Now see this type 4B, in type 4B, this extrahepatic part of bile duct is diseased. What you do, you remove this extrahepatic part of bile duct. Now you have to restore the continuity. How we are going to restore the continuity? So here, with the help of a loop of jejunum, we are going to restore the continuity, and this is Roux-en-Y hepaticojejunostomy. So here also what? Roux-en-Y hepaticojejunostomy, and in type 4B also what? Roux-en-Y hepaticojejunostomy. Clear? Type 3 is a bit different. Here there is dilatation of terminal part of interduodenal part of bile duct. Here we go for endoscopic sphincterotomy and cyst unroofing. So this is how we manage the choledochal cyst. So see the treatment. Obviously for type 4A and for type 5, we go for liver transplantation. For type 1, type 2 and type 4B, we go for Roux-en-Y hepaticojejunostomy, and type 3 is totally different. So for type 3, we go for endoscopic sphincterotomy plus cyst unroofing. Clear? Okay, now coming to the clinical features. One question which is frequently asked, that what is the characteristic triad of choledochal cyst? So because of cyst, what happens? There is mass, and in the cyst, what happens? There is recurrent infection. Patient is having recurrent attacks of cholangitis. So this patient is having what? pain, and there is jaundice. So there is mass, pain, jaundice. Question is asked that which kind of jaundice is seen in patients of choledochal cyst. It is continuous jaundice or intermittent jaundice. So see, there are recurrent attacks of cholangitis. So patient is going to develop jaundice, then it disappears, then develop jaundice. So it is what? Intermittent jaundice. So clinical features, it is characterized by a triad. And what are the components? There is mass, there is pain, and there is jaundice. What kind of jaundice? You have to highlight, because this is the question which is frequently asked. What kind of? It's intermittent. It's the intermittent jaundice. Now what is the most common symptom overall? If you see, the most common symptom, it depends on the age. So most common symptom in patients less than 2 years of age. So the most common symptom in patients less than 2 years of age, that is jaundice. And if the age of patient is more than equal to 2 years, here the most common symptom is abdominal pain. This is abdominal pain. Clear? Now see, what are the complications in choledochal cyst, and the symptoms or clinical features are mainly dependent on the complications. So see the diagram. This is the liver. Here, this is the gallbladder. This is the cyst. This is the pancreas, pancreatic duct, and duodenum. Now in the cyst, there are chances of formation of stone. So if the stone is formed in the cyst, it is known as cystolithiasis. So whenever there is stone formation in the cyst, it is cystolithiasis. Because of this stone, there is obstruction, and because of this obstruction, what's the problem? There is infection, and this infection is what? Cholangitis. Now see, whenever this stone is coming down and it is going to obstruct the pancreatic duct, because of obstruction of pancreatic duct, what's the problem? There is pancreatitis. So see, here there is cystolithiasis, there is cholangitis, and what else? Here it can lead to pancreatitis. Right? Now if you see this diagram, in this diagram there are 5 organs, and the choledochal cyst is going to increase the risk of malignancy of all those 5 organs. And see, this risk persists lifelong. So the risk is there in the patient lifelong. So one question is asked that even after surgery of choledochal cyst, for how long patient requires follow-up? So lifelong follow-up, right? So what organs are there? Here you can see choledochal cyst increases the risk of malignancy of liver, gallbladder, bile duct, pancreas, and duodenum, right? So in all these 5 organs, there is increased risk of malignancy. Out of these 5, the maximum risk of malignancy is seen in, obviously, which organ? It's the bile duct. And what kind of malignancy is seen? Obviously, in the bile duct, there is cholangiocarcinoma. So the question is asked indirectly that what is the most common site of cholangiocarcinoma in the choledochal cyst? Obviously, within the cyst, because there is maximum inflammation. And within the cyst, which wall is most commonly involved? It's the posterior wall. So what is the most common site? It is the posterior wall of the cyst. Posterior wall of the cyst. Clear? This is frequently asked question. Now coming to the diagnosis, what is the investigation of choice for diagnosis of choledochal cyst? It is the MRCP. So diagnosis, the investigation of choice for diagnosis, this is MRCP. Clear? And we discussed management already. We discussed that in type 4A and type 5, where intrahepatic bile duct is involved, the treatment of choice is liver transplantation. In type 1, type 2, type 4B, Roux-en-Y hepaticojejunostomy, and in type 3 we go for endoscopic sphincterotomy with cyst unroofing. Lots of students are having this kind of problem, that they are not able to understand completely MRCP, ERCP, PTC. Right? So it's very easy to understand. Let's discuss these three investigations in detail. First of all, MRCP. Right? So what is this MRCP? The full form is, it is magnetic resonance cholangiopancreatography. Magnetic resonance cholangiopancreatography. It is purely diagnostic. So MRCP is purely diagnostic investigation. What is MRCP actually? It is T2 phase of MRI. And you know that MRI is done in which department? Radiology department. So MRCP is done in radiology department. It is T2 phase of MRI. What happens in T2 phase? See, there are fast moving liquids in the body like blood. So fast moving liquids like blood, tissues, fat, all these are signal void. Signal void means all these things are not having any signal, and that's why these appears black. And the slow moving fluids in the body like bile and pancreatic juice are having high signal intensity. And since bile and pancreatic juice is having high signal intensity, it appears white. So on MRCP, on this T2 phase, fast moving fluids like blood, tissues, fat, these are signal void, means having no signal, and that's why these appears black. If you see the slow moving fluid like bile and pancreatic juice, bile and pancreatic juice, these are having high signal intensity, and because of this high signal intensity, these appears white. Right? So sometimes in Viva, examiner is going to confuse you that what is the contrast given in MRCP. We don't give any contrast. Why? Because bile itself and pancreatic juice itself appear white. Right? Acts as a contrast. So we are not supposed to give any contrast. Right? How it looks and in which conditions MRCP is investigation of choice. Let me tell you. In the bile duct and in the pancreatic duct, any kind of anatomical abnormality is there. In majority of cases, the investigation of choice will be MRCP. So see the list. MRCP is investigation of choice for diagnosis of first CBD stone, second choledochal cyst, third biliary strictures, fourth cholangiocarcinoma. See, it's not only MRCP which is investigation of choice. In cholangio, it's MRI plus MRCP. So actually speaking, it is MRI plus MRCP. Fifth, primary sclerosing cholangitis. Sixth, pancreas divisum, and seventh is chronic pancreatitis. Okay. So what you noticed here, that any condition in which there is stricture in the bile duct, stricture in the pancreatic duct, like in chronic pancreatitis, there are strictures, stone. So in all these cases, the investigation of choice for diagnosis is MRCP. Now see how it looks. Here you can see that this is the liver outline. Clear? This is the intrahepatic bile duct and this is the extrahepatic bile duct. Now here you can see what? That this is a duct. So you can see that this is the pancreatic duct and this is what? Bile duct. Now what you are going to notice in this MRCP, you can notice that this is the pancreatic duct, and here you can notice that this proximal part of bile duct means in the CBD, if we see the distal and proximal, in the CBD, the proximal part of CBD is dilated. And after that, what you are going to notice that there is abrupt narrowing. Clear? So since there is abrupt narrowing, what's the problem? Here, there is growth. It means there is malignancy leading to the obstruction. So you notice that there is obstruction here. It means this patient is having what? This patient is having cholangiocarcinoma involving this distal part of CBD. Clear? Now see this image of MRCP. So here also you can see that this is the basic liver outline, right? So this is intrahepatic bile duct and this is extrahepatic bile duct, right? Now see, this is what? Pancreatic duct, and this is what? The bile duct, and it's going to enter where? In the duodenum. So now you can see easily. What you are going to notice here, you can notice that here is the stricture. There are multiple strictures involving both intrahepatic as well as extrahepatic bile duct. So there are multiple strictures involving both intrahepatic and extrahepatic bile duct. It means this is what? This is a case of primary sclerosing cholangitis. Now what is the biggest limitation of MRCP? MRCP is purely diagnostic investigation. So if there is stone, you cannot remove. If there is stricture, you cannot put the stent. So to take care of all these problems, we can go for ERCP, and that's why the conditions where intervention is required, ERCP is gold standard. So you know, in CBD stone, ERCP is gold standard. Biliary strictures, ERCP is gold standard. Primary sclerosing cholangitis, ERCP is gold standard. Here also ERCP is gold standard. Why? Because it can remove the stone, and for stricture it can put the stent. So this is ERCP. And what is the full form of ERCP? It's endoscopic retrograde cholangiopancreatography. So with the help of endoscope, I'm going to inject the dye from below. You inject the dye from below. This is retrograde. And where exactly you are going to inject the dye? You are going to inject the dye into the pancreatic duct, and you are going to inject the dye into the bile duct. So this is endoscopic retrograde cholangiopancreatography. We discussed that this is both, it's both diagnostic and it's therapeutic. How it's done? See, this is the endoscope. In endoscope, there is a camera either at the tip or at one side. So if it's at the tip, it is known as end weaving endoscope, and if it's on one side, it is known as side weaving endoscope. So first, which endoscope is used in ERCP? We are going to use side weaving endoscope. Right? We are going to inject the dye from below into bile duct and pancreatic duct, and then we take X-ray. Who is going to perform ERCP? It is performed by gastroenterologist. Clear? Now in this picture you can see that there is a stone, and with the help of this Dormia basket we are trying to extract the stone. So this is therapeutic. In this image you can see that there is stricture. Clear? And since there is stricture, I'm going to insert a stent. Can you see this blue colored stent? So for stricture, I'm going to insert the stent. This is endoscopic retrograde cholangiopancreatography, which is both diagnostic and therapeutic. But what is the problem? In all cases, you are not able to remove the stone. You are able to remove stone only from the distal part of CBD, and you are able to insert the stent only for the strictures which are located in the distal part of bile duct. Now see one example. Suppose this is the site of stricture, okay, and where is the stone? Stone is located here. So if stone is located in the proximal part of bile duct, proximal to the stricture, so it's not possible for you to remove that, right? So what are the indications of ERCP? In which cases we use? It is used to remove stone from distal part of bile duct and put stent in the distal part. Now imagine a diagram or a situation. Suppose this is the situation. Clear? Here the patient is having permanent stricture, and proximal to this permanent stricture or non-passable stricture, proximal to this non-passable stricture there is presence of stone, or there is presence of stone into this intrahepatic part of bile duct. Imagine a stone is located here. So how you are going to remove this stone? See, I can easily remove this stone via, can you see, via PTC. So percutaneous transhepatic cholangiography. Via skin I am going into the liver, via liver I am entering into small bile duct and then into large bile duct, and then I am going to extract the stone with the help of Dormia basket. If there is any stricture, I can easily put a stent. So see, the conditions in which you were using ERCP, it was the distal part. If the similar situation is there in the proximal part, we are going to use what? PTC, right? So what's PTC? PTC is percutaneous transhepatic cholangiography. Again, it's both diagnostic and therapeutic, and it is used to remove stone, and insert stent. Right? Where exactly? In the proximal part of bile duct. So proximal part or intrahepatic bile duct. Clear? So MRCP is purely diagnostic. ERCP and PTC are both diagnostic and therapeutic. ERCP for distal part and PTC for proximal part. Now we are going to discuss CBD stone, which is also known as choledocholithiasis. So CBD stone, it is also known as choledocholithiasis. See, you have seen many patients of gallstones, right? Whenever a patient of gallstone is coming to us, we send the patient for ultrasound, because ultrasound is the investigation of choice for diagnosis of gallstone. One, whenever we are planning a patient or we are taking a patient for lap cholecystectomy, we have to rule out CBD obstruction. So generally we go for liver function test. In the liver function test, if patient is having raised bilirubin, it means there is CBD obstruction. So patient is having jaundice, or sometimes on LFT you are going to see that bilirubin is raised. Patients who are asymptomatic and they have CBD obstruction, what happens? Their ALP is raised. So we have to rule out CBD obstruction with the help of LFT. Now see, if a patient of gallstone is there, in how many patients there is presence of CBD stone also? In 6 to 12% patients of gallstone, there is presence of CBD stone. So in 6 to 12% patients of gallstones, there is presence of CBD stone. CBD stone is of two types. One is retained and one is recurrent. Retained means it is detected within 2 years of cholecystectomy. Recurrent means it is detected after 2 years of cholecystectomy. So two types: retained and recurrent. Okay, retained stone is detected within 2 years of cholecystectomy, and recurrent, it is detected after 2 years. Okay, this is one classification. There is second one. One is primary CBD stone and one is secondary CBD stone. Primary CBD stone means the stone which is formed primarily in the CBD, and secondary CBD stone means stone is formed in the gallbladder and then it slips and then comes into CBD. So what are the types? Primary CBD stone and secondary CBD stone. Right? It's very easy to understand. See, this is liver, this is the gallbladder, this is bile duct, this is duodenum. Clear? Now where is the stone? Stone is going to be formed in the CBD. We discussed in gallbladder that which stones are more common in CBD because of worm infestations, and that's brown stone. So this stone is formed in CBD, What's the most common type? It's brown stone. Brown stone, it is more common in developing countries or developed countries. So obviously developing because of worm infestation. And which worms we discussed? Ascaris and Clonorchis sinensis, right? Now secondary CBD stone, you can see the diagram. This is liver, this is gallbladder, this is bile duct and duodenum. Now see, the stone is formed in gallbladder and then it slips. Then it slips and goes into CBD. So which stone? In gallbladder, the most commonly seen stone or most common stone in gallbladder is cholesterol. So here also, what's the most common type of stone? So this is cholesterol, right? And this is more common in developing countries or developed countries. So this is more common in developed countries. Clear? So these are the types of CBD stone. See, if there is CBD stone or any kind of obstruction in CBD, generally there are three parameters which are abnormal. So what are those parameters? Laboratory parameters. There is raised alkaline phosphatase, so raised ALP, raised GGT, GGT means gamma glutamyl transpeptidase, and raised 5' nucleotidase. So what are the parameters? Laboratory parameters, which are raised. First, there is raised ALP. Second, raised gamma glutamyl transpeptidase, and third, 5' nucleotidase. So this is 5' nucleotidase. Okay. In patients of CBD stone, there are two presentations. One, patient is asymptomatic, and second, because of CBD obstruction, patient is having jaundice or its complications. So see, clinical features. There can be two presentations. Either this patient is asymptomatic, okay, or this patient is having jaundice plus minus complications, with or without complications. Okay. So see, what are the complications? If you see, this is liver, this is gallbladder, this is bile duct, right? There is a stone. Because of this stone, there is obstruction, and because of this obstruction, there is infection, and that's known as what? Cholangitis. When the stone comes down, it is going to obstruct the pancreatic duct, and because of that, patient can develop pancreatitis. Because of presence of CBD stone for long duration, there is inflammation. What kind of chronic inflammation? And because of this chronic inflammation, it can increase the risk of cholangiocarcinoma. So these are the complications of CBD stone, right? We discussed that what is the investigation of choice for diagnosis of CBD stone? MRCP, which is purely diagnostic. And what is the gold standard investigation for CBD stone? It is ERCP, because it is diagnostic and therapeutic. So see, diagnosis, investigation of choice for diagnosis of CBD stone, and that is MRCP. Gold standard investigation is ERCP. Why? Because ERCP is diagnostic and therapeutic, right? Now, how we can easily remove the stone? We discussed that we can easily remove the stone from CBD by ERCP, but there is upper limit. What's that upper limit? The maximum size of stone which can be removed by ERCP is 1.5 centimeter. So if the size of stone is more than 1.5, we have to perform choledochotomy and we have to remove the stone. So see the management. If the size of stone is up to 1.5 centimeter, we are going to remove it by ERCP. And if the size is more than 1.5 centimeter, we have to perform choledochotomy. Simple. some of the students are confused between ERCP and ESWL. See, ERCP is used to remove the stone of bile duct and ESWL is used for renal stones, right? So, question, ERCP, this is used for CBD stone, and what is the maximum size of stone which is removed, and that is 1.5 centimeter. And if we see ESWL, extracorporeal shockwave lithotripsy, this is used for renal stones. And what's the size up to 2 centimeter. So that's why you have to remember, because these are the two commonly asked questions. Now how we are going to perform choledochotomy? See, this is liver, this is gallbladder, this is bile duct, and this is duodenum, right? See, here there is a big stone, size more than 1.5 centimeter. What I'm going to do in this case, I'm going to perform the choledochotomy. So longitudinal incision is given, and after giving longitudinal incision, you are going to remove the stone, right? So what you do, you remove the stone, and after removing the stone, we have to check the patency of bile duct. So see how we check the patency. You have to insert infant feeding tube and you have to flush the saline. Clear? So if there is no obstruction distally, what you do, you can easily close the choledochotomy. So close the choledochotomy. But you notice that there is distal obstruction and there is stricture. There is stricture. In this case, what you can do, since here choledochotomy was done, so what you can do, this was the choledochotomy. So you can create a communication between bile duct and duodenum, and what? Create a communication or create a mouth. And after that, what will happen? This bile starts going into duodenum, right? So we suture that communication, and that is known as what? Choledochoduodenostomy, right? This choledochoduodenostomy is optional, not done in all the cases, only done when distal obstruction is suspected. Okay, so we perform choledochotomy, okay, and if distal obstruction is suspected, we go for choledochoduodenostomy. Choledochoduodenostomy. This question was asked in names. If distal obstruction is suspected, right? Now in exam, where you do the mistake, because in clinical scenario the examiner is giving the size of stone, right? And sometimes the size of stone is more than 1.5 centimeter, and in options the first option is ERCP, and in excitement most of the students are going to mark ERCP. So you have to look at the size of stone. Up to 1.5 go for ERCP, more than 1.5 go for choledochotomy. Now we are going to discuss cholangitis. Again, very important topic. See, for cholangitis there are two mandatory factors. One is obstruction and second is infection. So what are the two mandatory factors for cholangitis? One is obstruction and second is infection. These are the mandatory factors. It means any factor which can obstruct CBD, that can lead to cholangitis, right? So what are the predisposing factors? What are the predisposing factors? So what's the most common cause of CBD obstruction? Obviously CBD stone, and that's the most common cause of, or most common predisposing factor for cholangitis. So first, CBD stone. So obviously biliary strictures. We discussed choledochal cyst, cholangiocarcinoma, and we discussed worms, sometimes worms, right? Now what is the pathophysiology? It's very easy to understand. See this diagram. So here, what's the most common predisposing factor? There is CBD stone. because of this CBD stone, what happens? There is obstruction and there should be infection. Question: what is the most common organism responsible? And the most common organism responsible is E. coli, E. coli followed by Klebsiella. E. coli followed by Klebsiella. Right? Now see the problem. What's the normal CBD pressure? The normal CBD pressure is 10 to 12 centimeter H2O. So the normal CBD pressure, and that is 10 to 12 centimeter H2O. Very low. Whenever there is obstruction, what happens? This CBD pressure is going to rise. Whenever this pressure is more than 25 centimeter H2O, there are two refluxes which are going to occur. One is cholangiovenous reflux, cholangiovenous reflux, and one is cholangiolymphatic reflux. So what is the problem? Lots of you are having this kind of wrong thought in your brain that in cholangitis the infection is confined to the bile duct. No. What happens? Because of cholangiovenous reflux, the infection is going into venous circulation, and cholangiolymphatic reflux, infection enters into lymphatic circulation, and from venous and lymphatic circulation it enters into systemic circulation. That's why if I'm sending the blood culture of patient of cholangitis, more than 50% patients have positive blood culture. So what? More than 50% patients have positive blood culture. Simple. Second, since patient is having systemic sepsis, what is the most common manifestation of cholangitis? It's chills. So how to remember? Cholangitis, CH, chills. So remember, cholangitis, there is chills because of systemic sepsis. Now if you see the predisposing factor, it's obstruction. So what is the easiest method to relieve obstruction? ERCP. If it's not possible or failed, we go for PTC. Not possible or failed, we can go for surgical treatment and we can remove the obstruction. Got it? Infection is there, so that's why in all patients of cholangitis, what we give? IV antibiotics. So this is how we manage. Clear? So see the clinical features. It is characterized by a triad, which is frequently asked. What's the name? That's Charcot's triad. Clear? What are the components of Charcot's triad? There is pain, there is jaundice, and there is fever. We discussed that patient is having systemic sepsis. So if there is inadequate treatment or if there is delay in treatment, it can lead to Reynolds pentad. So if there is delay or there is inadequate treatment, it can convert into Reynolds pentad. Clear? So what are the components of Reynolds pentad? There is Charcot's triad. So apart from Charcot's triad, there is shock and mental status changes. Shock and mental status changes. Clear? So most of the times when these patients are brought to our emergency, they are having systemic sepsis and some of them are having shock also. So what is the first step? Whenever the patient is brought to your emergency, put 2 large bore IV cannula, start IV fluids and IV antibiotics. Majority of patients are going to improve. Suppose patient is not going to improve after IV fluids and IV antibiotics, it means the obstruction is persistent. And in that case, you have to relieve the obstruction. Easiest method, ERCP with stone extraction, and if there is stricture, ERCP with stenting. Not possible or failed, it means it might be in the proximal part of bile duct or intrahepatic part of bile duct. Then we can go for PTC with stone extraction or stenting. And both of these are not available or failed, then we can go for open biliary decompression. So see the steps of management. Put 2 large bore IV cannula. Right? We have to give IV fluids and antibiotics, most patients improve. Clear? If patient is not improving, if there is no improvement, in that case we go for ERCP with stone extraction, or if there is stricture we go for stenting. Clear? If it's not available or failed, PTC. So if it's not available, or failed, we can go for PTC with stone extraction or stenting. If PTC is also not available or failed, if it's not available or failed, in that case we go for open biliary decompression, and this is very important, asked frequently in exam. How we do it? Open biliary decompression. So we take the patient to OT after resuscitation. What we perform, we give a longitudinal incision. You can see here. Here is the stone. Clear? You are not able to relieve or remove the stone with the help of ERCP. So we perform or give incision, longitudinal incision. So after choledochotomy, what you do? You remove the stone, and after removing the stone, what you have to insert a tube. The shape of this tube is like T. That's why it's known as T tube. See, it's a life-saving surgery. In some situations, distal obstruction is there, but we are going to leave the things. Suppose some more stones are present distally, or there is stricture also distally. Leave it, because it's a life-saving surgery. So you insert the T tube, and what will happen? The bile will start going out via this T tube. Right? After inserting this T tube on 7th to 10th day, what we do? We are going to instill contrast. So instill the contrast via T tube, and after giving contrast via T tube, take the X-ray. This investigation is known as T tube cholangiogram, performed on 7th to 10th day. If T tube cholangiogram is performed and you notice that there is no distal filling defect, freely contrast is going into duodenum, it means there is no distal obstruction, you can remove the T tube. But if you are going to notice that there are distal filling defects, it means there is obstruction. So you have to retain the T tube for 4 to 6 weeks. Why? So that there is formation of granulation tissue over this T tube. And after 4 to 6 weeks, when the granulation tissue is formed over this T tube, what we do? Via this track of T tube, I'm going to insert the Dormia basket, and after inserting this Dormia basket, I'm taking the stone out. This is percutaneous extraction of stones, and this is known as Burheen's technique. So there are 3 questions which are asked. See the questions. First, on which day T tube cholangiogram is done? T tube cholangiogram. So it is done on 7th to 10th day. In cases of distal filling defects, retain the T tube. Retain the T tube. In cases of distal filling defects, for 4 to 6 weeks. And percutaneous extraction of stone. Percutaneous extraction of stone is done via which technique? Via Burheen's technique. Via Burheen's technique. So what are the questions which are asked? On which day T tube cholangiogram is done? 7th to 10th day. For how long we have to retain the T tube? 4 to 6 weeks. And by which technique we are supposed to remove the stone, or percutaneous extraction of stone is done via which technique? Burheen's technique. One question is asked where most of the students are doing the mistake in exam, that out of primary biliary cirrhosis, and primary sclerosing cholangitis, which one is more common in males and which one is more common in females? See, if we see primary biliary cirrhosis, this is more common in females. And if we see primary sclerosing cholangitis, this one is more common in males. So how to differentiate? See, you must be knowing this fact that most of autoimmune disorders are more common in females. And see, primary biliary cirrhosis is an autoimmune disorder and it's more common in females. Primary sclerosing cholangitis, it's more common in males. So what are the autoimmune disorders which are frequently asked in surgery? First, we discussed primary biliary cirrhosis. You know the important feature of autoimmune disorders, that autoimmune disorders are associated with autoantibodies, right? So primary biliary cirrhosis is associated with which autoantibody? It's associated with anti-mitochondrial autoantibody. Second is Graves' disease. And in Graves' disease, which autoantibody is there? It's LAT's long-acting thyroid stimulator. So this is LAT's long-acting thyroid stimulator. This is also known as thyroid stimulating autoantibody against TSH receptor. So this is thyroid stimulating antibody against TSH receptor. Just opposite of Graves, that is Hashimoto's thyroiditis, and Hashimoto's thyroiditis is associated with anti-TPO antibodies. Third is Hashimoto's thyroiditis, and this one is associated with anti-TPO. The full form of TPO is thyroid peroxidase. And the fourth important in surgery, fourth one, and that's pernicious anemia, right? And in pernicious anemia, there is autoantibodies against parietal cells. So here, autoantibodies against parietal cells. Clear? And you know, all these autoimmune disorders are more common in females. So one by one we are going to discuss. First we are going to discuss primary biliary cirrhosis. You know, in primary biliary cirrhosis there is progressive destruction of intrahepatic bile ducts only. And we discussed any condition in which there is only involvement of intrahepatic bile duct, or there is involvement of intrahepatic bile duct, you cannot repair that. And that's why what's the treatment of choice? It's the liver transplantation, right? So we are going to discuss primary biliary cirrhosis, right? So first important point is that it's autoimmune disorder and it's more common in females. The questions related to pathology, it is characterized by progressive destruction of intrahepatic bile ducts only. And what are the diagnostic pathological features which are frequently asked? In this case, you have to remember these terms because these terms are asked in exam. Florid duct lesion, granulomatous inflammation, and lymphocytic infiltration, right? These are the diagnostic appearances. So if these are the diagnostic pathological appearances, what is the investigation of choice for diagnosis? Obviously biopsy, where you are going to find these appearances. Okay, now the problem, these patients have pruritus and fatigue. The two most characteristic symptoms of this condition is pruritus and fatigue. Now see the important points. If you see any patient of obstructive jaundice, generally these patients, any other patient of obstructive jaundice, generally the patients of obstructive jaundice are initially having jaundice, later they are going to develop itching or pruritus, right? So generally first patient is going to develop jaundice and then pruritus. Primary biliary cirrhosis is the only condition where pruritus precedes jaundice. First important point, pruritus precedes jaundice. Second, this was asked many times in exam, that pruritus is most bothersome in morning or evening. So this pruritus is most bothersome in evening. So clinical features which are frequently asked in exam. First, pruritus precedes jaundice. Pruritus precedes jaundice. Okay. Second, pruritus, it's most bothersome in evening, right? And the two most characteristic symptoms are pruritus and fatigue. Pruritus and fatigue, these are two most characteristic symptoms. Now see, this condition is associated with hyperlipidemia, and because of hyperlipidemia patient is having xanthomas and xanthelismas, right? You have seen xanthelismas in diabetic patients of hypothyroidism who are going to have hyperlipidemia, and the patients are also having melanosis. Melanosis means hyperpigmentation of skin. So what are the associations of primary biliary cirrhosis? It is associated with hyperlipidemia, and because of this hyperlipidemia there is xanthomas and xanthelismas. Xanthomas and xanthelismas. Clear? The patients are having melanosis, that's hyperpigmentation of skin, and we discussed patient is having anti-mitochondrial autoantibody. Anti-mitochondrial. So anti-mitochondrial autoantibody, right? These are the associations. We discussed that investigation of choice for diagnosis of primary biliary cirrhosis is biopsy. Now see, one of the good thing related to autoimmune disorders, since autoimmune disorders are having autoantibodies, you can make the diagnosis with the help of autoantibodies. So two questions which are asked here frequently: diagnosis can be made with the help of autoantibodies, but investigation of choice for diagnosis, and that is biopsy. Since intrahepatic part of bile duct is involved, so what's the treatment? The treatment of choice is liver transplantation. We discussed that pruritus and fatigue are two characteristic symptoms. In this condition, pruritus and fatigue are so severe that these are indications for liver transplantation. So liver transplantation is also done in patients who are having severe pruritus and fatigue. Generally in other conditions, what is the hepatic failure directly or indirectly, which is an indication for liver transplantation, but here pruritus and fatigue are so severe that these are indications for liver transplantation.